The next talk will be by Dr. Sadaf Ali, who is Professor and Head Department of Surgical Gastroenterology at SKIMS Srinagar. And she'll be talking to us and sharing her experience on current standards of lymphadenectomy for carcinoma stomach. Dr. Sadaf Ali, over to you.
As
Please
a
go ahead.
part of continuation of management of gastric cancers, I have been assigned to discuss the current standards of lymphadenectomy for gastric cancer. I know much has been covered by the technical details spoken by Dr. Kalayasan and previous speakers. A little brush up of what they had put yesterday, that all those lymphadenectomy standards evolve around the AJCC staging system, which puts the gastric cancer into early and advanced, where early is stage T1 and advanced are T2 to T4. And the nodes have the significance of N1 to N3, where one to two nodes are N1 disease and N2 is 3 to 6, and then N3 is 7 or beyond, where when 16 or more lymph nodes are involved, it is N3B. So, what are the various lymphadenectomy described in literature? The lymph node drainage of stomach are classified basically at three levels based on the anatomical location of the tumor in context to stomach. So it is level 1 to level 3, and it is different for different areas of stomach, as we understand that the stomach is a large organ. The nodes in the first group are the perigastric lymph node 1 to 6. Those in second group are along the branches of celiac artery 7 to 11 plus 12A, and those in the third group are 13 to 16. So based on this, actually we define the gastrectomy into D1, which involves removal of perigastric lymph node at tier 1. D2 is G1 plus removal of the lymph nodes along all parent vessels which supply the particular area. D2 plus is removal of the node beyond, designated as tier 2 for D2. And D3 has a little gray area, but it describes lymph nodes which are in N3 nodes. In addition to all this, subsequently as a part of standards, station 7 is included in D1 dissection for all types of gastric cancer, all areas of gastric cancer. Now, what is the significance of, I'll just short, this is obscuring. What is the significance of the adequate lymph node? The concept of complete removal of all lymph nodes likely to be involved is based on the site of the tumor, making a huge difference in survival, was first introduced by Japanese. They actually showed the world that there can be a significant survival benefit with level 2 lymph node clearance, and labeled it as due to gastrectomy, as we all were discussing. It gained place to be as a standard in all surgical treatment in all major guidelines, and subsequently there was introduction of D2 plus and D3 gastrectomy that may be required in certain subset of patients. This is not standard, but this was further consolidated with a lot of literature and evidences showing that the lymph node ratio and the rate of non-compliance lymph node clearance are very important prognostic factor. So more than cure, it actually hovers around prognostication of the disease. The lymph node invasion is the primary prognostic and prognostic factor of gastric cancer. Minimum of 16 lymph nodes are mandated to stage and prognosticate the disease. Removing even more than the designated is all the more welcome. There's a lot of study on this, and it's a core hope for better prognosis. Now, studies have demonstrated that the higher the lymph nodes examined and removed, it correlates to better post-gastrectomy survival, especially in stage 1 disease. The 5-year survival is assumed to be, is actually documented to be long back, not in the era of present NACT, which will be discussed by the later speakers, 70 to 80%, 30% in N1 and 5% in N2, which has improved after increasing the number of lymph node in resection. So the background of this concept evolved all over world once there was initiation taken by the European 3 trials, the famous, the MRC, the Dutch trial and the Italian trial, which made an attempt to compare the standard D1 to D2, and subsequently after initial no early survival benefit and a low level of agreement to the procedure shown by Japanese. After 15 years, they poured in find more data that it is definitely better when compared to D1 in subset of patients who have an advanced disease. The Italian trial showed benefits both at 5 years as well as 15 years. The D1 group had at 5 years 59% survival versus 38%, and on subsequent follow-up, the disease-specific survival and the mortality related to gastric cancer was significantly low in D2 group when compared to D1. So they proposed that if the morbidity can come down, because they had a lot of morbidity, which they assume to be related to two factors: the training or the skills of the surgeons in the European subset when compared to Japanese, understanding of D2 gastrectomy, as well as contributing it to removal of distal pancreas and spleen as a part of the procedure. Then poured in many more randomized controlled trials coming in from East, backed by China, Korea, Taiwan, which looked into D1 versus D2. So what is peculiar over here about the lymph nodal dissection is that this kind of studies actually showed clearly that the morbidity is not and the mortality is not which was shown by the European world. But the D1 and D2 are almost at par with the survival, except for one or two exceptional studies which showed reverse. And this is how now it's a standard practice and gained a place in your NCCN guidelines, where the disease of early gastric cancer needs endoscopic resection, or in medically fit candidates, it might need a surgical procedure mounting only to D1, and those which have disease beyond, the standard is perioperative chemotherapy followed by D2 gastrectomy. So is the European guidelines, believe in multimodality modality treatment in all advanced gastric cancer. And but a little difference should be discussed over here about the Japanese guidelines is that they don't give away with M1 disease, and when it is M0, their protocol is that early gastric cancer is endoscopic, as well as if it is, they recommended is if the disease is into the submucosa, then a D1 or D1 plus gastrectomy would be more appropriate, or if you cannot do it for the mucosal resection endoscopic. As well as they also recommend that all those patients who have T2, T4, if they don't have bulky lymph node, D2 gastrectomy is appropriate. But if they have bulky node, they go for NAC followed by D2 and even D2 plus lymphadenectomy. For M1 disease, they recommend that there should be, if it is a resectable liver metastasis, and if the disease is in the circle of N4, because they put it a little differently, N1, N2, N3, which I'll come down later on. They recommend a post-neoadjuvant chemotherapy, consideration of D2 gastrectomy plus a periaortic lymph node resection. You can put it as D3. Some of them also put it at D4, and the others go for palliative care. So there's a consensus now by almost all guidelines. If you see the French, the NCCN, the ESMO, and the Japanese, that all those patients who are advanced will require a D2 gastrectomy, and those who are early would require an endoscopic or a D1 gastrectomy. But the Japanese still prefer a splenectomy to be added in the greater curvature tumor, and the French add it when it is T3 or T4 tumor over there. So the standard of lymph node dissection now is definitely D1 for early disease, T1A and 0, and anything beyond would require D2, D2 plus, and D3 is for bulky nodes. And once there's a clear evidence that there are lymph nodes at level 3. So just a brushing up for the knowledge of students. We have already discussed yesterday, as Kalaisaran showed, that it's not that station 4 is station 4, which can be generally named, but you have to understand it in context to what are the parts of station 4 lymph node, what you have to leave and what you have to take away. So this is what is they describe as N1 up to station 6, N2 up to 11, 12 to 14 are N3 level node, and N4 are the lymph nodes which are 15 and 16. So a good D2 gastrectomy, whether open or laparoscopic should have a clear view like this, that you have cleared all your stations 7, 9, 11P, 8A, if required, add 8P and the 12P and A. What is different in different site of the tumor is when you're planning a D2 gastrectomy for a different level of gastrectomies for a total gastrectomy demanding tumor, say the tumor is somewhere in between, then all D1 has to go away, which is in blue. So all 1 to 6 goes away in a total gastrectomy. In D1 plus, you have to add the station 7, plus 7, and D1 plus, you have to add station 8A, 9, and 11P, which is then in the orange color over here. And in D2, you add in the total gastrectomy the 11D and the 12A. Now, coming to a distal gastrectomy, which is more commonly and simply performed, it is mentioned over here about D0 because it's all based on skill and the understanding of the procedure. Many beginners, assuming even a D1 gastrectomy, misunderstand the specimen of D0 with missing lymph nodes, as he said, in G junction, and there are some difficult lymph nodes in, especially in laparoscopic and demanding surgeries. So D1 in distal gastrectomy include station 1, 3, 4SB, 4D, 5, 6, and 7. So the station 2 and the short gastric area may be spared, and D1 plus would add 8A and 9, and the standard D2 would also have 11P and 12A included. For proximal gastrectomy, there aren't many proponents, but those who believe in organ preservation in STIWOT type 2, type 3, and some smaller lesions, you have to go for a standard D1 would be 1, 2, 3A, 4SA, 4SB, and 7. And D1 plus will include 8A, 9P, and 11P over here, which is different from the other. They are the blue and the orange. And a standard D2 will also include the station 11D in addition to this, the distal node along the splenic artery. So how we go about it in the open procedure is, if you see, this is almost a T4 lesion. And this patient is, can I just take it forward with my cursor? Yeah. So unlike what he said that they leave the omentum to the last, we have good place for traction and we do it early in the procedure. And then we move on up to distal gastrectomy. So once we mark an area where we need not collect lymph nodes from, they all come station 1 along with the omentum. And then the right gastric stem, it's very important that we take pedicle kind of a nodal tissue rather than taking it away in picking up and taking it away in piecemeal. This is what we had discussed yesterday also. So coming to the after division of the lesser omentum and greater omentum, then you start dissecting, do away with the duodenum and create a traction, and then you start appropriate D2 clearance. Here it's very important that you meticulously use your energy devices. If you are a beginner and you are likely to post fire, pass point, then this kind of electrocautery may not be recommended. It would be good if you would bipolar energy sources, which can be more focused and causes less collateral injuries. The nodes are to be separated in en masse, and we have to start, usually the dissection starts, as you said, along the common hepatic artery, and you tend to clear all the tissue. You avoid breaking the tissue and taking it into piecemeal, and most of the time it's not very difficult to take the posterior part of the nodes, stepping up with more lymph node gain. We on an average usually get, as we progress doing it, and it's a state where the disease is very common, from we are not restricted to 16 nodes. Usually on an average we get 25, 28 lymph nodes in a specimen. So the staging is quite adequate if the lymphadenectomy is done in an appropriate and proper way. And then you move to the left gastric after doing the celiac, the proximal part of the splenic, the common hepatic. And if required, you find a positive node, go posteriorly. If you find a positive node, then you should also go to the hepatic artery based on your planned gastrectomy if you want to do beyond D2. There's absolutely nothing about if you master a procedure having lot of post-operative lymphoria, because what we believe in is that the stump of the disconnections at the base, we tend to put some amount of ligatures or uh, liga clip. So rest is the usual way that you decide where you are going to, sorry, where you are going to do your level of disconnection and reconstruction. Now, something more about the standards of lymphadenectomy, what we have to do in patients with early disease T1 and 0. But you have to do a D1 plus when the tumor is more than 1.5 centimeter. The tumor is poorly differentiated. You have to extend it to inclusion of station 8A and 9. And in cases of total gastrectomy demanded in the smaller lesion, you have to include the 11P. So it becomes a more extensive procedure. Uh, and you have to consider D2 plus in certain areas again in where you otherwise would have done a D2, especially in patients with those who have tumor which is bulky on the greater curvature and in close proximity of hilum. You need to remove hilar node, and sometimes it may end up removing a spleen. And D2 plus may also be required in patients who have distal malignancy, where you have a definite or confirmed or obvious station 6 node involvement. Then you should think about removing the 14 V lymph node, which is along the superior mesenteric vein. And if you have a duodenal invasion in distal gastric cancer, there are recommendations, though these are not standard recommendations or inclusion in guidelines, but you should take the lymph node, which is 13P, which comes along the posterior side of the duodenum. So, then if you have an obvious extensive lymph nodal disease and it's an advanced disease, a diffuse involvement of stomach, and you're doing it post neck, you can go stage it up to D3 and involve the stations 16 nodes in your dissection. So consideration of the periaortic lymph node is based on the argument that if D is more than N, the recurrence is likely to be less. And the periaortic nodal involvement is usually seen if you based on studies in 30% of the patients, and you to target them. Otherwise, it will eliminate the stage migration. And then, but this is not backed up with addition to survival data. Initially, when Japanese showed interest in this, they could not document survival benefit 69 versus 70 in D2 and D3. And subsequently, at present, recent years, there's a renewal of Japanese interest in picking up D3 lymph nodes for tumors which are more than 5 centimeter. There's a recent phase 2 trial wherein they have reported that with inclusion post neck the periaortic lymph node, the survival is quite good, 53%, 59% at 3 years and 53% at 5 years. So usually what we see, the trend of survival is a good gastrectomy actually shows the survival benefit at longer term. And even the gastric cancer study group recommends it to be considered in diffuse type of lesion. Now, a word about these kind of the literature support. There are people who have studied on it and concluded that there is a better survival in patients who have in definite involvement of 14B, and this should be included in the dissection of D2. And what exactly is the node is the node over here at the root, and we have to along the superior mesenteric vein. You have to identify and remove it. Now, when you look into data of D2 plus, there are few meta-analysis where people have tried to look into it, and they have said that there is a survival benefit if removed and assumed to be positive with over 5 years. Uh, and they have also shown that D2 plus, if you involve those concerned lymph nodes, the disease pattern of involvement is proven to be in 7% in 8P, 5.1% in 12P, 13% in 5.7% in station 13, and again 7.1% in this is one among those meta-analysis. And regarding para-aortic lymph node, again, it is all depending upon those which have positive, confirmed, and those who are negative. If they are positive, there is a trend towards survival benefit, but you may end up removing the lymph nodes which are not actually positive. So this study in green actually has taken into consideration those who were proven to be pathologically positive, and dissection of those kind of lymph node actually takes it up from 13% to 28%. Uh, so. Uh, how do we take a call about going beyond D2 gastrectomies if you see a positive lymph node, something like this at the root, and if the tumor is otherwise resectable? So we look into the area. In fact, we are actually doing a study. We could
Uh,
a very
Dr.
yeah,
Sadaf, you'll have to expedite. Yeah,
yeah.
yeah.
So
Sorry
we
to
have.
interrupt.
If you are into the para-aortic lymph node clearance, you should be knowing that what lymph nodes are to be removed. A1 and B2 are not the lymph nodes, but you have to take the A2 lateral and internal, and B1. So the concept now, a little bit about, I'm just finishing concept of sentinel lymph node mapping. It's also important when we discuss the lymphadenectomy with context to doing away with unrequired kind of lymph nodal removal. This gives you an exact navigation and helps to remove the actually required node, and give an equivalent results of standard D2 gastrectomy. This is also likely to add organ preservation. There has been a meta-analysis which has proved that the radiocolite tracer with dye injected within the tumor can actually guide you to correct navigation in 82 to 88% of the cases. It has a definite role in early disease T1 and T2 with low nodal burden, which can be picked up with good CT or EUS, and this can be tried. Recently, there's also an interest in using ICG to be promising in this field, and it has a better role to be played in minimal invasive surgery. So I'll just skip away with some studies and logical results which they have shown with a better a good result or at par result in group of those navigated and non-navigated. Of course, the inclusion criteria are strict. So, for example, what they have put up in their study is that what you end up in removing so many lymph nodes and the so much of tumor, you can actually preserve and remove very little over here, and there can be an organ preservation as well as lesser morbidity. And then we have already discussed, they have already discussed whether it can be translated into the laparoscopic or the minimal approach. We have less results of the robotic, but we have good amount of results of early gastric cancer in laparoscopic approach. These are the Korea and the Japanese, the class trials, still ongoing trials, which he gave a little reference. But in early gastric cancer, it has a similar role. But once you have to do an extensive lymphadenectomy, there's a lot of heterogeneous results reporting, which says that it's very difficult, or there is a low threshold to have a compliant lymph node in station 4, 6, 9, and 11. And some of them, they also report it to be on station 4. But then we have to have go with the present this thing, and in experienced hands it will have a similar result. So I would summarize that I did not put up any take home message, that you have a primary tumor and an early disease, then D1 lymphadenectomy, the circle increases as the disease is advanced, and it you go to D2 for metastatic disease. There is still a role of D2 plus and periaortic lymph node in subset of selected subset of patient. And of course, you have the red area where you don't have much to offer. Thank you, everybody, for your patient hearing.
Thank you very much, Dr. Sadaf, for such a very comprehensive lecture on the standards of lymphadenectomy in gastric cancer. Uh, the panelists, one or two quick questions because we're a little bit short of time. Any questions from the panelists?
Over.
The presentation can be closed, Dr.
Yeah. I'll
Sadaf,
close
so
it.
that you will be visible on the screen.
Yeah.
Can I just start with the question?
Yeah, please.
Nice presentation, Dr. Sadaf. You mentioned about the use of ICG in guiding the lymphadenectomies. So it has been known to be useful in early gastric cancer. So what is your opinion on advanced gastric cancer? Because I just share with because we thought we'll did a pilot study, but what we have found is many times in advanced gastric cancers, the ICG does not go beyond the initial enlarged nodes. So our idea was we'll use ICG to find lymph nodes that are beyond D2 so that we can selectively do those D2 plus. But that was not, helpful.
Exactly. At present, it is all a navigation of early gastric cancer and maybe some in between stage with low nodal node. But if you are expecting an extensive nodal load, then it might not be good. But it's all in primitive phase. I think your center is a better center. You gave carcinoma gallbladder ICG navigation also some time back. I had seen somebody presenting. We don't have any experience in doing it, but this is what is maybe the way forward.
Thank you, Dr. Kalidasan. Any more questions? Okay, I have a question from the participants who are viewing this program. Dr. Sadaf, this is from Dr. Vihar Kotecha. How far would a lymphadenectomy go for a distal gastrectomy T3 disease with no nodes in 1 to 4 in the tier 1 nodes? Will you take 1 to 3 nodes too? That's the question.
See, for distal gastrectomy, one has to come because the arc of the lesser curvature is so short that we always remove station 1. Once it is a question of station 2, the stump in subtotal gastrectomy, usually you do subtotal, and the station 2 are cleared, but you have to take care that you don't take away the vessel. So station 2 and a part of even 4 short gastric may not be required, are not required actually, even in a part of D1. So it's exactly where the tumor location is. So tumor location is distal. You have to know that what is its basin 1 and what is its basin 2. Again, its level 2 are different. Its level 2 will not include a splenic hilar lymph node. Its level 2 will include the lymph nodes which are along your hepatic artery. Maybe sometimes if you want to go beyond, you will go behind the common hepatic artery and the hepatic artery proper. And the distal gastrectomy, as I discussed earlier, it's a very, very, the core of the chunk of the lymph nodes are in the station 6. So you have to be very careful while removing the station 6 nodes. None of the lymph nodes should be left behind because that's a primary or the tier 1 lymph node. And once you are done with station 6, you should have a very vigilant inspection that there some lymph nodes along the 14V. So 14V might be required to be removed, which is not a part of D2, but it would definitely add if it is positive. Then if it is negative, it doesn't have much to do. But if it is positive, then you are doing away with disease, which might be left behind. But that would become a D2 plus gastrectomy. Hope I answered that question.
Yeah. Thank you very much. One question from my side. You have told that in early gastric cancer, we can do D1. Are there any other setups in locally advanced gastric cancer where D1 might be necessary? Necessary in the sense that D2 may be difficult or challenging.
It might be difficult in patients who are morbid. So if you are not able to do an extensive procedure, if the expertise is less, say if you are doing a gastrectomy, I have done quite a few patients with D1 gastrectomy who had frank Child's B cirrhosis and CS stomach. And you cannot give based on that you cannot produce evidence, but you have few cases who actually do very well even with D1 gastrectomy. So we
What
have been
about emergencies when a
yeah,
patient
in,
is bleeding?
in a bleeding emergency case, if the expertise is so the level of skills in D2 gastrectomy is maybe you say in at the level of what you are doing right now, and for the beginners and the junior faculty, they may end up doing a D1 gastrectomy in emergency. But then you have to take into consideration that if you can do a limited D1 plus, it is always in favor of patient. Another indication would be they recommend it for stage T1B to do D2. But if the tumor is smaller in size, say if it is 1 centimeter, then a D1 gastrectomy may suffice.
So just to summarize, maybe when, as you said, mobility is there, very elderly patients who may not sustain a prolonged operation, or in emergencies when things are compromised, we may have to step down and consider a D1 instead of D2, even if the expertise is available. Okay, I think thank you very much.